Hello, everybody, and welcome. So protect the pulp using bioactive materials. That's our webinar tonight. And my name is Marty Jablow. I'm America's Dental Technology Coach. I'm one of Dentistry Today's CE leaders, and I'm one of the people who picks the Cellrent Best of Class Technology Awards. And so why am I being the one to give this webinar tonight? Well, all technology, it's not all stuff that gets plugged in. In fact, most of the new technology in dentistry revolves around chemistry. And that's really our big thing these days is chemistry. Whether it's nanoparticles, whether it's 3D printing resins, all of these things, revolve around chemistry, and we don't think about that much. We take it for granted, but those biochemists and chemists who design all this stuff, very smart people. And so tonight, this is a different kind of technology, but, it's all still new. If you have any questions, on this topic later or after the webinar, or if you've watching this at some point, delayed, you can get a hold of me, Marty, dentaltechnologycoach.com, or through my website. That's easy enough to do. You can find me online if you Google me. I have a blog. I'm on Twitter, LinkedIn, and all those other fun social media sites. You'll find me somehow, some way, and can get me a question if you need it answered. And I want to thank Septidont for sponsoring tonight's webinar. Without their assistance here, we wouldn't be here because I wouldn't, and neither would you. So again, big thank you to Septidont for being tonight's sponsor. So let's talk about it. What are we trying to do? What is the dental pulp? It's a soft connective tissue. It's mesenchymal in origin, and it's in the pulp chamber of the teeth and the root canals. It's an internal tissue, and it's extremely sensitive. I mean, that's what it is. And there are many different irritants to the pulp. The one that we really encounter most of the time in dentistry is the bacterial portion. That's where the caries invades the tooth and didn't get treated early enough, and we get breakdowns such as this, where we have a carious exposure, maybe even a toothache. That's what we mostly consider, at that point, how deep is the caries, are they symptomatic? And we're going to get into that a little bit later. And then we also have trauma, from fractures, subluxations, avulsions. All of these things can also irritate the dental pulp. And then chemicals, temporary and permanent restorative materials can lead to pulpal injury. And then cytotoxicity, acid, heat, marginal leakage, all the stuff that we talk about in the chemistry of restoring a tooth. We all know that no dentistry for the most part can last forever. In fact, the tooth itself didn't last forever if we have to, intercept some disease process. So again, all of these things, can impact the pulp. That's why we use water when we're using a high-speed handpiece to keep the temperature down. We don't want to necessarily put acid etched directly on an exposed pulp. We want a little bit of distance there. All of these things come into play. And because of all these irritants, we need pulpal protection. We need to be able to do things to protect the pulp, because if we don't, we wind up usually with the need for endodontic therapy, extraction. All of these things can necessitate, greater expense and complexity to the practitioner. So every day in our practice, all right, we see all of these things coming at us, all right, and in many of them, we don't even stand the chance against it, because by the time they get to us, it's too far, too late. Especially when we have like caries as pulp exposures. If we've just got dent and caries, for the most part, enamel caries, we can protect that, that pulp. But once it gets to too deep, it's not going to happen. Then if it's a primary tooth and we do a pulpotomy, we're in direct contact with the pulp. We can do pulpotomies and pulpectomies in in an adult tooth. We can also perforate through the pulp chamber, or perforate a root. And then we have things like resorptions, both internal and external. We may need to do an apexification procedure or apical surgery. I mean, all of these things present a challenge to the tooth. And then what do you do when the pulp is exposed? You know, and everybody's got their go-to method. I mean, that's just a fact, based on different criteria that we were taught in dental school, what we may have learned in classes along the way. We get these various things. And you don't necessarily treat every pulpal exposure the same. As you look at these photos, that one on the upper right is minuscule. That might be treated significantly different than that molar that we're looking at below it. How big, what were the things involved that got us there? Very important pieces of the pie, of the questions that we have to answer as the practitioner, the person who's going to treat this. We need to know exactly what we're going to do, when these things happen. And this is what I was just saying. There's many ways to get there, and not all of them, may be correct, but all of them may be. It depends on what your philosophy is, what the literature says, how big an exposure, what do you have available to you? I mean, that's another thing. In every office, sometimes, in my office, I stock certain things. What if that's not there? What's the next go-to thing? If you're an associate and you're traveling between different offices, you may have different materials in different offices. And, you have to understand, when I get into this situation, what's there and what am I going to use? So there are different products, different chemistries. We can put composite over a pulp. We can put GIs, glass ionomers or comprimers or calcium hydroxide, MTA, or now we've gotten into the pulp. We did a pulpotomy. We stick formicreosol in it. MTA, calcium hydroxide. We used to use amalgams to do apicoectomies way back. All right. We don't see that now. But again, these things have all been done. GI has been used, for that also. So again, I just extracted a tooth that, had a very nice apico done on it. But ultimately, 6 months later, it failed. So now tooth is out, bone graft, and, we're going to place an implant. But all of these things, matter. So what are the challenges in these? All right, how are we going to manage, an exposed pulp, deep caries? What happens if you perforate while you're, accessing the pulp chamber? What if you get resorption? How do you handle that? If you've got a situation of developing tooth and you're going to do apexification, how are you going to handle that? What's the best things to use? And these are all pieces of that puzzle. And there are questions that you have to ask yourself so that when you're ready to do the procedure, you're not thinking, now what? So let's go through these indications. A small mechanical exposure of the pulp during preparation is really just trauma. Yes, there's caries, there may be some infected dentin, but for the most part, we've all been in this situation. The caries went a little deep, we may have nicked the pulp horn, and what are we going to do there? Same type of thing. Minimal exposure on that picture from the trauma. How are we going to handle that? Again, different ways to do it. But what are the bigger things? The contraindications, how we should just, forget about protecting the pulp at that point and say, hey, we need to do something more. We're not talking minimally invasive anymore. We're talking maximally invasive at this point. If you've got caries that's totally exposed the pulp, that's not a good indication for trying to protect it unless you don't have developed roots. All right, in a young person, maybe first or second molar and the roots have not fully formed. Now we have to, talk about how we're going to do that apexification, and what are we going to do. If the tooth hurts, that's also not a good indication for doing anything at that point. Trying to make an irreversible, pulpitis into a reversible one, for the most part, doesn't work. I've seen some studies out of Europe that, they get, 20 and 30%, maybe get some, resolution. It's not good enough for most people. I don't want people coming back in pain. So at that point, I'd rather commit them to endodontic therapy. Pain, spontaneous pain, it's a toothache. That's not good. Excess mobility, +2 and +3 mobility, again, not working in your favor. Again, at that point, you got the thickened PDL. You may have periapical pathology, in which case the nerve tissue is already, dead, and that's why you've got that, pathology, and you probably have an abscess going with it. All right, spontaneous bleeding, any kind of infection. These are all the things that we're looking at that just say, time out. It's time to initiate endodontic therapy, not try and protect something that's already been, compromised significantly. So what have we used in the past? We used zinc oxide eugenol, IRM. That's what I was taught in dental school. Seems like, a long time ago, because it was, and that was the go-to material, right? Then when the glass ionomers came along, we were using those, and composites, and there was the whole idea that you would just etch and put the composite over it. And then we have, of course, calcium hydroxide, the dical, which was, been taught for many years, and then fell out of favor. But new research is showing that dical has some place back in protecting the pulp. And of course, MTA, which is, one of the more newer materials in this space, and has seemed to work quite well and has very good research to back it up. So let's look at this. Zinc oxide eugenol, all right, it's been used in dentistry, like I said, forever. It's a direct pulp cap, but it's questionable because the eugenol is highly toxic, all right, and it releases this into the pulp, and for the most part, we're not sure that this thing is really, really going to solve the problem. It may calm it down for a slight period of time. It's probably not going to be the thing that's going to maintain the vitality of that pulp. Because here, as you see, the conclusion was all the concentrations of eugenol that they evaluated produced high toxicity in human dental pulp fibroblasts in primary teeth. All right, this is it. It's going to whack at it, and you're going to wind up with a situation, maybe not immediately, but somewhere down the road. Then we have glass ionomers and RMGI, resin-modified glass ionomer, and again, they're also cytotoxic when they're in direct contact with a dental pulp. And they're, the conventional formulations of these are less toxic. I mean, GI is also acidic, and these are things that we have to be aware of. Now, the good thing is GI does bond to the tooth, all right, and that's going to stop your micro leakage. But it's good, it's biocompatible, but it's not to be in direct contact with the pulp. So, a glass ionomer, I'm a bigger fan of glass ionomers than RMGI because I just found that RMGI just doesn't have the best properties of either composite or glass ionomer. So if you want to use a glass ionomer strictly as a base, in a, moderately deep caries, that's okay. I think that's a good use. You're going to get a very good seal. Your base basically is another restorative material. So you're going to layer that in most cases with a composite. Here in the States anyway, you would layer it with a composite. I know in many places in Europe and in other areas, they restore many teeth just with glass ionomer. So again, not a bad thing, but you don't want the glass ionomer coming to in direct contact with the pulp. All right, so what about direct pulp papping with RMGI? And again, chronic inflammation, the dentin bridge didn't form, even at 300 days, so almost a year, compared to the calcium hydroxide group, it wasn't working very well. So again, it's there, you can use it if you've got nothing else, not a big fan. And then what about composites, all right? And, this is from 2009. When we look at that, what if we put a direct composite over it? And if you look at this right now, and you can see based on the time, anywhere from 1 month to 2 months to 3 months to 10 months, all of them had worse outcomes than just using calcium hydroxide, all right? So, really don't want to go there. It's just so much easier to place calcium hydroxide and then place something over it. In which case, if you have a pulpal exposure, you might want to place some calcium hydroxide. Then you might want to put in a different base or etch, and then put your composite over it. But directly placing the composite on the tooth, and again, whether it's total etch or self etch or whatever you're going to do, you're not going to see the same results as if you just use plain old calcium hydroxide. So, composite is not really indicated as a pulp cap. So calcium hydroxide, it's the gold standard. That's what, for 30 years or so, since I was in dental school, that's what we were taught. But like I said, it kind of fell out of favor for a little bit because we didn't understand it. We were getting some newer materials, and now we're kind of looking at it a little bit differently than we had in the past, and that's a good thing, because sometimes we're told one thing, the research starts heading in one direction, and somewhere later we find that that research wasn't really what it told us. So again, calcium hydroxide, it's got great antibacterial properties. In one study, they found 100% reduction in microorganisms associated with pulpal infections after just 1 hour of contact. I mean, that's it. Caries is bacteria. We want to kill caries, we kill bacteria. And it's got that, like I said, it's got that long-term track record. And nothing else has that kind of backup. The problems are, though, it's highly soluble, so it'll wash out. Many of us who've taken out old restorations, especially amalgams, we'll see that all, it's just all kind of mushy in there from when it's been in there. I just had one the other day, though, that I took a composite out because it fractured, and you know what? It was pretty good, the calcium hydroxide under it, because it was sealed very well. But the calcium hydroxide by itself, there's no adhesive properties to it, so it doesn't seal. It's not like glass ionomer that will actually seal the tooth. This is going to be quite different, so it just kind of sits there. It's bioactive, all right, so that's the key here. For a while we weren't sure of all these things, but we now know that calcium hydroxide is bioactive. It's known that the properties, the variety of the proteins in it can be incorporated into the dental matrix, all right? And all of these different things, the bone morphogenic proteins and the growth factors, they've all been stimulated by calcium hydroxide. And that's really the important thing, that in the contact, these things will stimulate the dental pulp to start repair, all right? And that's what we're looking for. We want the pulp to heal itself. The body, when it can heal itself, does a much better job than you or I can, and that's it. The unfortunate thing is we can't heal dentin and enamel once it's been lost to the disease or trauma, so that's where we have to use something else. Then MTA, mineral trioxide aggregate, came along, and this was a big deal. This kind of changed things because this stuff worked extremely well. This was pricey, all right? But it worked very, very well, and this is, one of the things that, has lended itself to be kind of my go-to for a good period of time. This was my go-to thing if I had to do a direct pulp cap, if I perforated while I was doing endo and needed to repair it. And with very good results. So what it does is it's a silicate cement. It produces calcium hydroxide, which we've already discussed is known to be bioactive. The good thing is it does seal tooth structure. So that's much better when they're looking at calcium hydroxide, because we will get a seal, and it has a very, very high amount of calcium hydroxide in it. So it can continue to nourish the dentin and the pulp and build those dentinal bridges. And that's why it's important. There are some issues with MTA because it also is very soluble. At the beginning, there was gray MTA, which would make some teeth look dark. That's now pretty much been taken care of because you can get a white MTA, but it takes forever to set. This was the thing. You couldn't restore the tooth quickly. Many cases, you would place a temporary in it and then have to come back, for another visit. And compared to DiCal, MTA was quite expensive. That was the big thing about it, was, what are we going to do, with that? So MTA got better results than calcium hydroxide. All right. There's many studies showing that. Here's one: MTA had a higher success rate and less pulpal inflammatory response, and it hardens quickly compared to calcium hydroxide. And it was definitely a suitable replacement for calcium hydroxide, in direct pulp caps. This was from the Journal of Endodontics in 2015. But then we had biodentine came along. And I see some questions coming in. We're going to get to those questions all at the end. So biodentine came along. And this kind of changed it up because I could get those benefits of MTA, but I also got things that were better enhancing, which I could restore the tooth immediately. There's a whole bunch of stuff that made this a really game changer. All right. Basically, they called it dentin in a capsule. So you would triturate this and shake it up, and then you'd put it out and you'd place it. And we're going to get into that. But there's more than 10 years of research and development by Septodon about this. It's very biocompatible. All right. It does promote healing just like calcium hydroxide. It will preserve pulp vitality both in direct and indirect pulp capping techniques. It has the same mechanical properties as dentin, so it hardens up and cuts very nicely, kind of like many of the core buildup materials. It's made from tricalcium silicates, and it's good for root perforation repairs, resorptive lesions, apexification, and pulp capping too. So it's a really good tool in my toolbox. When I have something that's gone wrong, well, whether it's a caries exposure or a mechanical exposure, or I've got apexification that needs to be done, or like I said, some iatrogenic thing where I'm searching for a small pulp chamber and unfortunately didn't find it, perfed the tooth a bit, now I have ability to repair that. And, that's really important. So it's a very good, material to have in your office. It stores well, it's less expensive than MTA, and it's easier to use. So there's two parts. There's the powder and the liquid, and you are going to mix this up, and it's pretty easy to handle. They've got this high quality tricalcium silicate, and they make sure that you're going to get the most calcium hydroxide out of this. All right, so that you're going to get a very, very good result as best you can. It's up to the body, don't forget, but you're going to give the body the greatest chance it has to get, to heal itself. That's really the important part. So what's happened? It's gentle to the pulp, all right, and it preserves and promotes the pulp vitality. So it's really a good healing piece to this puzzle. It acts like dentin. It starts to penetrate into the dental tubules immediately and stimulates the odontoblasts. So you're going to get that dental bridge to form, and that's what we're looking for. And we get that tertiary dentin, that hard stuff, the stuff that you go in and you take that spoon and you start to scrape, and it's not going anywhere. It also has a very high compressive strength. So again, it's even more sort of harder there than dentin. You don't have to prep the surface, okay, so it's going to seal. All right, it's got a very high pH. We get zero linkage. We're going to kill off bacteria, all right, and there's no shrinkage. And the color is going to look better because we're looking at a white, not a gray. So what are the benefits? It saves you time because you can actually just bulk fill this thing up. It's self-set, it's self-curing, so you just let it, you can fill the whole pulp chamber up, or if you're doing an apexification procedure, or if you've got that small little exposure, use the whole thing as a base. Just build the biodentine up. It acts like dentin, it cuts like dentin. You'll think it's it's simple to do. There's no micro leakage, so that's really the big thing. And the key here, the big difference is instead of looking at hours for set time with MTA, you're looking at 10 to 12 minutes. So that allows you to do a couple of things. That allows you to be able to complete this procedure in one office visit, and that's really important, is that you can do this in one visit and, put a composite over the top, or you can actually, if you wanted to, you could just leave the biodentine in there, all right, and fill it up completely. And, that has about 6 months worth of time that, you can leave it in there. So it's really something, it's a great material for whatever your needs may be at that moment. So if you look here, the compressor strength, we can see here how much biodentine is greater than dentin itself, and enhanced glass ionomers and MTA. And calcium hydroxide basically has no compressive strength. So let's look at a couple of different things. We're going to look at this in regards to biodentine, in regards to MTA, all right, and dical. And we're going to look, the highest compressive strength is biodentine. It's going to be the strongest material. The lowest one was MTA, and there was no micro leakage, right? Real important, again. This was from 2012. Biodentine demonstrated no micro leakage. So, that's really the important part here, is that, once it's sealed, it's just going to be better. I mean, that's what we're looking to do. Better seal, better result. And here's just a photomicrograph you can see of, how it looks between the dentin and the biodentine. Here's another one, all right, just to show you, how it looks. This is, again, it's penetrating into the dental tubules, and you're going to get a much, better result. You're going to get good penetration, good seal. That's really how you're going to stop caries, or you're going to stop, bacteria from penetrating it. So between the high pH and everything else, we've got everything working for us. So again, now we're looking at biodentine. This is from 2017. It's recent. It had better cytocompatibility and bioactivity than MTA, Theracal, and IRM when it was in contact with stem cells from human primary teeth. Again, we're looking for the most biocompatibility. Many of these things may work, but I want it to work most of the time, not half the time, not 25% of the time, and I want them to be safe. The biodentine surface exhibits the thickest surface calcium hydroxide concentration, all right, compared to MTA, dical, and Theracal. All right, so yes, in some of these things, I mean, I've used all of these things. Obviously, dical is easy to place. Theracal comes in that little syringe, and it's light cured. Sometimes it doesn't stick real well, but these are all the things that we're looking for. And which one's going to give me the most bang for the buck in terms of how's it going to work? Again, biodentine seems to come out the winner. Here's another one, that's just showing higher mineralization, all right, than MTA. Like I said, this one I think is 20, trying to see this one, can't see it. But, again, we're looking at, just everything is more enhanced and it's easier to place. That's what I'm saying. So let's look at a couple of cases. Let's see what we've got here. So this is just, you've got a deep carious lesion. You're looking at it. You want to base it up. Again, just simple enough. You can place it into the tooth. You let it set 10 to 12 minutes, and then you can restore this tooth any way that you feel like is appropriate. At that point, you've got a good seal. I'd recommend placing a good direct composite. I know those cusps are getting a little bit thin there. And I could probably make a good comment for placing a crown, but at that point, you could, if that was the case, build this whole thing up in MTA, make sure everything is good, give it 30 days if that's the case, and then, prep it just straight for a crown. You wouldn't have to do a core buildup. All right, here's another one. So let's look at this case. You got the lower right first molar. It's got big interproximal decay, and what we see here is that with a direct pulp cap, using MTA, we start to see that remineralization process. All right. And, I've seen this with glass ionomer. I've seen it with, other materials, because once you take the offending, bacteria out of the situation, the body will attempt to repair itself. And, again, at this point, I want the good seal. That's really what it's all about, is sealing this tooth. So if you can get in there and you get that good seal, you will start to see reparative dentin. And, that is the key. Sealing this thing, giving the body a chance, as far as I'm concerned, that's the goal. All right. Because if we may win some, we may lose some, but, if you can't seal it well, it's a problem. It's the same thing when you do endodontics. I usually try and do my core buildup the same day. I want to seal that thing and keep it, the outside world, in, because I know plenty of times when I've put in, a cavit and the patient doesn't get around to coming back quickly enough, and they come in and they're all missing and they're digging food out. How do most endos fail? From the top down. So again, seal is important in all of dentistry. Here's another one with a pulp cap. All right, he had some pain due to food impaction, caused caries. At that point it was excavated. Direct pulp cap using biodentine was placed. Then at some point later, a month and a half later, that fractured. And again, 5-month post-op, we've got, the tertiary dentin being laid down. It's asymptomatic, and the pulp is normal. I mean, these are really the keys here. Is, like everything else, it's case selection, but this is one of those things that gives you a real fighting chance when it comes to handling pulp exposures, both carious and non. So here's another one, where just build the whole thing back up. You had deep caries on a bunch of these teeth. You could excavate them. If you got that exposure, which you can see there, you just place the biodentine and let it sit. That's it. Let it sit. You've got time. You can come back, take care of all this other caries, take care of all the issues, make sure that, tooth pulp, responds favorably, that it's not, causing a problem. You can pulp test it later. And, if everything's good, then you can just cut back some of that biodentine and then just bond over it. Now you've got a long-term easy restoration to do, and you're going to get a good result. So as a temporary material, biodentine is approved for 6 months. That will give you plenty of time to assess, the vitality of the pulp, whether this is going to work for you or not, based on, patient symptoms. Plain and simple. You've got the time, and take advantage of it. You can go anywhere from the direct restoration, in 10 to 12 minutes, or you can wait this out. So it gives you a lot of leeway, and, you get to decide what methods, are going to work for this patient. Also works in pediatric teeth. So again, we're looking at something like this, where, if I just had caries in many cases now, I may not even anesthetize the child. We can get most of the caries out without it. If we're going to get into something like this, obviously I would want anesthesia, and you can just then place, this material as a direct pulp cap. And again, same thing, 6 months. Depending on a person like this, on this kid at age 11, we're going to, he delayed loss of teeth here, but, that may just last him through losing those teeth. Simple enough. All right, so how about success rates in pulpotomies performed with biodentine and primary molars, all right, compared to former Cresol? I know a lot of that's former Cresol worked very well. Again, one of those products that's been around forever, fell out of favor due to some other, cytotoxic issues. And, again, what we found is it works, all right? And you don't have all those toxicity issues that come with it. So again, it's about killing bacteria. In the case of formicrosol, it would kill it, but then you had to do something else. In the case of biodentine, you can clean it, you stop the bleeding, you put it in, build the tooth all the way up. That may get you through. That may be it. No other treatment may be necessary. So when compared to calcium hydroxide and vital pulpotomies in primary molars, all right, biodentine gave us the good regenerative potential with high clinical success, and it's using basically calcium hydroxide, but in a better form. That's really it. So if you were mixing up a big thing of calcium hydroxide, you couldn't put it in the tooth. All right, it's not going to work out well. So now you've got high concentrations of calcium hydroxide working extremely well in your favor in a restorative or interim restorative material that's going to allow it to work for you, and it's going to make you more efficient with a potential better outcome. So again, it's really something to be looking at. So a couple of clinical tips. You want to use a metal or plastic instrument to place this. All right, use 6 drops of the liquid, all right, to get you to the right consistency. You want to put something on your matrix band, kind of like if you were placing a GI. You want to lubricate it somehow so that it doesn't stick, and when you pull it off, it doesn't pull the restoration with it. And again, if you're going to use it as a temp, as an interim restoration, you can then, just go in and remove part of it and use it as a base, and then, place your material of choice over it. So let's compare biodentine and MTA. All right, one's a 30-second mix in a capsule. The other, you got to mix it on your glass slab. Your initial set's in 6 minutes. The other one's 70. Final set's 3 hours for MTA, and the other one's 10 to 12 minutes with biodentine. So again, you can go straight to your final restoration and not worry about it. It's got high mechanical resistance compared to the low of MTA because it takes forever to set, and you're going to get more adhesion, all right, with the biodentine than you will with MTA. So again, it's that seal that we're looking for. MTA works. I'm not going to tell you it doesn't, but I get all of the benefits of MTA plus, and I get the ability for a material that's easier to use, less expensive, and it's just got all those enhanced properties. So it's really something that I like to have around. Don't use it on a daily basis, but again, it's something that's always in my office. It's in that toolbox when I need it, and always thankful when it is. So here's something new. This is just from this month. It's not about protecting the pulp, but I just thought it was a really interesting study about biodentine. All right, and this was it's the Italian Endodontic Journal. All right, and it was what they were trying to do. They were evaluating outcomes on endodontic treated teeth that were perforated, and some of these were old perforations. These weren't something that, just happened right now. These were old perforations that had some kind of pathology associated with them, and they were looking to see whether they could retreat these with calcium hydroxide or biodentine and what was going to happen. All right. What they did was the study used students. Now, I always like some of these that use students because they really want to just show, the fact that this stuff works. And if it'll work in students' hands, just being, with faculty supervision, you know what? Most of us should be able to get better outcomes than that. So what they did was they used both of these, and they, treated 51 patients and then monitored them over 18 to 64 months. So they examined 51 of these teeth, or 40, and 48 were classified as healed. So 94% of them of these, perforated lesions were healed. All right, and so the outcome really was, in the single visits, biodentine provided a biocompatible and effective seal in an acidic environment from root perforations, even if the treatment was performed by an inexperienced operator and regardless of the location, the size, and the time of the occurrence of the perforation. So, you know, is this a miracle material? There are no miracle materials. But when you look at stuff like this and you say, wow, long-standing infection, big problem, and we can fix it, you know, students can fix it, you know, you got to look at this material and go, this may be that biocompatible material that we're looking for, and we can use it in areas that, you know, maybe we don't always think about. Maybe we can save teeth that we couldn't have saved otherwise. And, you know, this research, like I said, it's from June of this year, just goes to that. So, you know, I think that you really want to just, you know, consider this as a great material. Like I said, it's a tool in the toolbox, and when you need it, it's there, and you're glad you have it. So it's time for questions. Let me go back through these. There's a number of them. Let me start at the beginning and see what we got. Well, it says, how about there's asking about Theracal and the same as calcium hydroxide. I think I've answered those. There's quite a few. You can go do your own research online if you'd like, but there's plenty of research that shows all of these materials. At this point, you know, I've used them, calcium hydroxide, I've used Theracal, I've used IRM, I mean, over the course of my years, MTA, Biodentine. Biodentine seems to be the easiest one for me to handle. All right. You know, Theracal works. I don't want to say it doesn't, but, you know, again, I want something that's what's the literature telling me is the best. And right now in my hands, I consider that to be Biodentine. All right. We got more questions coming in, so I got to scroll here. The success rate of MTA versus calcium hydroxide, again, you know, at this point, what I would tell you is that MTA is going to have a higher success rate because it will seal versus calcium hydroxide, that which doesn't. I mean, calcium hydroxide may be the factor that is really the bioactive material, but you're going to see MTA has the calcium hydroxide, so does Biodentine, and, you know, I want that seal versus non-seal. So in my case, I would say in that exact question, I would pick MTA over calcium hydroxide. Biodentine put in a tooth if there's caries. Well, yeah, I mean, if there's huge amounts of caries, no. I mean, you want to get as much of the caries out. If you want to start just short of, you know, a pulpal exposure, I don't have a problem with that. I think that that's not a bad technique. All right. In that case, if you think you've got most of it out and there's a thin layer of caries, you can put this in, and as you saw in some of those you know, pictures of those radiographs, you know, you will get remineralization. So if the body's still able to help itself, it will do that. So again, you know, even if there's a little bit of caries in there, I don't think that's a big problem. But you don't want lots of it in there. Somebody asked me something about limelight. I do not have any experience with that. How much does Biodentine cost? Well, again, depending on where you are and who's your supplier, Biodentine is going to cost significantly less than MTA. It's going to cost more than calcium hydroxide. All right. So, you know, there's a continuum here of what you're looking at. You know, a little tube of Dical versus, you know, Biodentine, you know, is between that and more expensive for MTA. Is formal creosol now contraindicated? Well, at that point, you're going to have to decide that for yourself. You know, what are the benefits? There's some issues with formal creosol. You know, doc, as long as you think it's fine, I'm not here to tell you what to use. I wouldn't call it a contraindication, but there have been some issues raised, especially in pediatric patients. You can do your own research on that. Next question is, how does this compare to leaving some dentin over Pulp and Fuji 9 with high fluoride? You're doing the same type of thing. All right, so I'm okay with that. You've got, the difference is you know, instead of a basic environment, you've got a very acidic environment when you're placing calcium, when you're placing GI, but you're looking to gain the same thing. You're going to get that good seal from a glass ionomer, absolutely. You're going to kill off some of the bacteria with the pH. I got that too. The problem is that pH may be more toxic to the pulp. but I got no issues with that. If you've got, again, you've got some caries, it's getting deep, you decide, hey, you know what, my material that I have and my material of choice, is some GC Fuji, hey, go for it. I got no issues with it. You're going to get high fluoride content, it's not the calcium hydroxide. So, depending on the situation, I'm going to agree with you that this may work, and I've done it. So, this became those treatments that were in favor of, many years ago, and occasionally I will still do something like this, where we talked about, open and closed sandwich techniques, where you couldn't get a good gingival seal, so you'd place some glass ionomer and then build it up, and then cover it over with some composite at that point, in an open sandwich technique. That was it. But yeah, I mean, that given that what that question asks, that may just work. Can you use it as a core? Yeah, I would use it as a core. I was explaining in that one with that premolar, where it was basically a base, and it cuts pretty much, like dentin. So at that point, I say you could use it as a core buildup. You're going to get a good seal, and you're going to place that restoration over it. So I don't think that's a really big deal at all, and I would feel pretty confident in that. How expensive is it? Again, it's more expensive than calcium hydroxide, less expensive than MTA, and that's just you'll have to check with your supplier about that. How do you sterilize the exposed area prior to placing biodentine? Okay, so the benefit of this is trying to do the least trauma to the pulp. All right. So in many cases, I would just as long as it's not actively bleeding. Because if you've got an active, big bleed in there, this is probably not going to be successful. But if you got that small thing and it basically stops on itself, I mean, there's many techniques where people have recommended everything from bleach to lasers. I'm more inclined that if I've got that little bit of exposure, the less I do is better. So the quicker I seal that, the better off it would be. And you're going to get this sterilization effect from the material itself. So I'm not big on starting to scrub pulps that are exposed with different chemicals. My thoughts are the less is better in that case. We've changed my mind. I've been using MTA for a long time. Now it's time to switch to biodentine. Try it. You're going to find that it works really well for you, and it just makes your life easier. And that's really what it's about. You've got, a material that I would say, from just the biocompatibility standpoint is just as good, if not better. But from the restorative point of view, you've got a much better material to work with. That's the biggest thing for me, is you get that benefit, right away. Biodentine, is it a root canal sealer, and is this possible? I would not be using it as in endodontic therapy that way. Now, having said that, where there's perforations, or you need it for apexification or something like that, and there's a real reason to do it, and that's the material of choice, I would say yes. In terms of a routine, endodontic procedure, no, this is not a sealer, and I would not use it in that manner. Can you use biodentine in an acutely painful tooth with a large pulp? What are the sensitivity issues? Well, here's the thing. If you go back to one of those first slides where I talked about it, if you've got a painful tooth, if you've got a tooth that spontaneously has pain, and we're looking at an irreversible pulpitis, the odds of us taking that irreversible pulpitis and making it reversible are quite small. So from that point alone, my job is to get my patients out of pain and not take a gamble that they're going to come back in pain. Not a good practice builder, not something that, I'd want to be doing, even if they were saying, hey, I really don't want root canal therapy. Do whatever you can to try and prevent it. The last thing I need is them coming in the next day, forcing themselves back into my schedule again and causing a problem. So, large pulpal exposures, this is not for it. large pulpal exposures require endodontic therapy, pulpotomy. Obviously, if it needs an apexification, that's a different discussion, but in a normal adult tooth, I wouldn't be doing it. Can you speak about the cytotoxicity of biodentine? You mentioned it was less than the others, but is it significantly so? Well, you know, everything that you put on the pulp is going to have some adverse effect. It's just how much. That's really what it comes down to. And you know, I don't have that study. I mean, we could, let me see if I can go. I don't even know what slide it is. You know, we can go back, but you know, it's a continuum. And you know, depending on the health of the tooth, you know, a healthy tooth can, you know, absorb more issues than an unhealthy tooth, so, or unhealthy pulp. So, you know, when we're looking at that, I can't give you an exact number of where it is and what is the point that you're going to cross over in terms of cytotoxicity. But when we're looking at some of those materials that were more cytotoxic, obviously those are known, and this was less. So if we've been using stuff like IRM for years, but that eugenol is cytotoxic and we know it, you know, and this isn't having that and we get less cytotoxicity, you know, I consider it to be very safe at that point. Can you use bleach to clean the cavity prep? You can. You know, I don't have a problem with that. You know, if that's what your normal technique is, you know, then go ahead and do it. But again, I wouldn't be doing that on an exposed pulp. I just think that, you know, the last thing I want to do is irritate it more and more. Does calcium hydroxide cause root resorption? Not as far as I know. I mean, we've been using calcium hydroxide in teeth forever. You know, if it was causing root resorption, we'd know about it by now. Is there any light cured calcium hydroxide bases? I believe there may be. I mean, you can use something like Theracal, which is light cured, but you know, directly a calcium hydroxide like Dical, I'm not sure. I'll be honest. I stopped using Dical many years ago when it started to fall out of favor at that point in time. I haven't picked it back up. If there was something that I thought I would be using calcium hydroxide for, since I don't have it in my office, I still have some Duralon cement, and I'd probably use that instead. Any plans to develop a biodentine product that doesn't need trituration? You're going to have to ask Septodon about that. You do need to mix this stuff, and I don't know the answer to that question. I'm not part of that team that would be able to answer that. I think you should go over about the contraindications. Contraindications to placing any kind of base, I think, or any kind of anything on the pulp. I think we did go over that. You know, again, large carious exposure, you know, mobility, spontaneous pain. There was a whole list of them that we went over earlier. Biodentine's been, how long's biodentine been around? Biodentine's been around, oh, I'm trying to think here. I'm going to say about 10 years. So it's not a brand new product. It's been out there. It's been tested, and it's worked well. I've been using it probably not quite that long, but you know, again, it replaced MTA for me. Is it compatible with silver diamine fluoride, or do you simply not use the SDF anymore? Well, again, I think we're looking at different things here. You know, it's the right material for the right job. So, you know, when I'm looking at using, you know, an SDF product, you know, it's usually to control caries in a out of control situation. All right. Where I've got either, you know, a child who's got rampant caries, or I have someone in most cases, you know, a drug abuser who's got rampant caries, where I'm trying to shut the caries process down in lots of teeth very quickly, versus, you know, a patient that's coming in with, you know, caries exposure, you know, that kind of thing. So I don't look at the two as the same. You know, obviously you can shut it down with SDF, but you got to go back in at some point. Shutting it down doesn't solve all the problems. It just, you know, it's an interim fix in many cases, where you can do something quickly. So at some point you're going to go back into the tooth, and then you're going to treat it, you know, as you would normally. So I don't look at them as the same product. I think it's a different product for different situations. All right, so that was the last question. Anybody else? Any other questions? I'll call it. Going once, going twice. That's it. I want to thank everybody for taking an hour of their time with me tonight. Hopefully we got something out of it. I got some good questions. I appreciate those. And you know, wherever you may be, whether it's going to be enjoy your summer or enjoy your winter, thanks for coming out. And I'll see you again on another webinar in the not too distant future. Thanks. Bye-bye, everybody.